Now let's officially dive into today's session, making sense of labs and genetic tests in ALL. So lab results are part of every ALL journey, but for many patients and families, those can feel confusing or overwhelming. Which numbers really matter? How do doctors use them to make decisions? Today's session is designed to answer these questions and give you confidence in understanding your results. That's why we're very grateful to be joined today by Dr. Wajis. He is an adult leukemia and cellular therapist specialist at MSK. So thank you a lot, Dr. Wajis, for being here with us. And I'm really honored to hear from you.
My pleasure. Thank you so much for having me. It's really a great pleasure to be with all of you tonight. And so let me share my slides so you can see them. Okay. Can you see my slides okay, Marlu?
Yeah, they look perfect.
Okay, excellent, excellent. So I'll tell you a little bit about who I am, and then we'll launch into the presentation. Mary Lou asked me to cover genetic and other laboratory testing in ALL, which I think is a very interesting topic because it's evolving quickly, and our tests are getting so much better, and they're giving us more information. So very happy to go through things. This is one of the first events that I've done in patient education, and so. Please let me know if anything that I'm saying is unclear. I know that we're going to do Q&A in the end, but if as I'm going there are things that just don't make sense, completely feel free to interrupt and say, hey, can you explain this again, or can you go into more detail? I'm more than happy to do it. So my name is Yanis Baltis. I am originally from Greece. I grew up there and I moved to the States when I was 18 to attend college. I went to Harvard for college and I studied biology. And it was actually there that I got very interested in leukemia from a scientific perspective. And then I stayed on at Harvard for medical school, and that's where I became very interested in cancer, not just from a scientific perspective, but from a clinical and from a human perspective. And I did my residency in Boston. And I actually did my residency in both adult internal medicine and pediatrics. I did adult medicine at Brigham and Women's and pediatric at Boston Children's. And that was a fascinating experience because, as many of you might know, ALL is a disease that affects both kids and adults. And I got to witness firsthand and learn both from the pediatricians and the adult doctors how to treat ALL. And it was a very interesting experience because, as some of you might know, it's a little bit different how we treat ALL in the different age groups. And then I came to New York and I did my fellowship in medical oncology. And now I practice as an adult medical oncologist. So even though I am a pediatrician by training, I no longer treat kids. I've also gotten a lot of experience in cell therapy, which is a very exciting and growing area in the treatment and hopefully cure of acute lymphoblastic leukemia and other B-cell derived malignancies. And that's kind of an area that I'm active in right now. I practice in New York City, in Manhattan, and also in Westchester County. And yeah, so I'll start talking about diagnostics and genetic tests. But again, if anyone has questions or if things don't make sense, feel free to interrupt me. My disclosures are that I consult for a company called Valius Sciences that does some advanced molecular diagnostics for patients. Nothing in the talk that I will discuss today has anything to do with Valius, but it is important to know that I have a financial relationship with them. So I'm going to give you some background in acute lymphoblastic leukemia. I'm going to keep this relatively brief because I want to get to the meat of the presentation, which is about diagnostics. And then we'll talk about what are the tests that we send off when we suspect someone has acute lymphoblastic leukemia and what do they mean. So that's kind of the initial diagnostics testing. Then we're going to talk about follow-up diagnostic testing. So, after a patient receives some treatment and we learn a little bit about their leukemia, what is it that we track and we follow? We're going to talk about the concept of measurable residual disease, which is a very important concept in ALL, and it helps us determine what is the best treatment pathway for someone. We're going to talk about how MRD is measured, what are the different ways that we can measure it, and how do they compare to each other. We're briefly going to talk about transplant. There are some tests that are very specific to patients who receive a bone marrow transplant. As many of you might already know, some patients with ALL will undergo a bone marrow transplant, but not everybody needs to do that. And so some of the testing that we'll discuss is a little bit specific to that subpopulation that will receive a bone marrow transplant. And then I want to leave a lot of time for your questions. As you can imagine, I cannot really comment on an individual case or provide medical advice in this forum, but I'm very happy to kind of go through any questions around, what does a test mean and how should I think about it? And if there are follow-up questions, I'm sure you all know how to reach Mary Lou and HealthTree. So acute lymphoblastic leukemia, or ALL, is the most common cancer in children. But something that many people are unaware of is that half of the people who are diagnosed are 17 or older. So even though it is a common cancer in children, it certainly does not only affect children, and it has a very kind of important presence in adult oncology as well. Here on the right, you can see the age distribution, and as you can see, there is a sizable number of what we call adolescents and young adults, or AYAs. These are the people, some people say 15 to 39, other times they say 15 to 40, to 49. But there's a sizable group of adolescents and young adults that have ALL, and they're a special population, and we've been getting a lot better at treating them in recent years. In terms of other epidemiological facts that are interesting, patients of Hispanic background tend to have higher rates of ALL, and we have some insight as to why that might be, but that's still an area of active research. And another thing that we know is that outcomes are worse with increasing age. So we're very, very good at curing ALL in children. We're up to 90, even 95% cure rates. We're not as good at curing ALL in adults, and that has to do with a lot of different reasons. It has to do with the fact that children are able to handle very strong chemotherapy, and sometimes adults that have other medical comorbidities and their other organs are impaired in some way might not be able to receive such strong chemotherapy. It also has to do with the fact that ALL tends to present a little differently and behave a little differently between children and adults, and children are more likely to have some of the more favorable ALL subtypes that are more likely to be cured with chemotherapy. And adults, unfortunately, are actually more likely to have some of the more resistant phenotypes of ALL that are a little tougher to cure with chemotherapy. Um, just a little bit about biology, and of course, this is not a biology talk, but I think it's important to give you a sense of the ALL biology because it's going to be very relevant to when we talk about diagnostics. So ALL is acute lymphoblastic leukemia, and it means that the cell of origin, the cancer cell, is a lymphoblast. And a lymphoblast is an immature lymphocyte. A lymphocyte is a part of the immune system, and we all have both B and T lymphocytes, and they are supposed to recognize foreign things in the body like viruses, bacteria, maybe even cancer cells, and try to get rid of them so that they can promote health. And when a cancer cell, when a lymphocyte becomes cancerous, it becomes a lymphoblast in some cases. Here on the right, you can see that when an immature lymphocyte becomes cancerous, it becomes acute lymphoblastic leukemia. When a more mature lymphocyte becomes cancerous, it might become something like CLL, or a chronic lymphocytic leukemia, or a lymphoma, such as diffuse large B-cell lymphoma. And then the terminal form of lymphocytes, specifically the terminal form of some B cells, is to become plasma cells. And plasma cells are cells that make antibodies. As you know, when a plasma cell becomes cancerous, it becomes multiple myeloma. And so in a sense, ALL, CLL, lymphoma, and multiple myeloma, they're all very related because they all are lymphocyte cancers. One of the things that is very special about lymphocytes, both B cells and T cells, is that they undergo a normal mutation process early on in their lifetime in order to be able to target all pathogens we may encounter. As you might imagine, your B cells and your T cells need to be able at recognizing not just this year's flu virus, but next year's flu virus and the year after that. And so because of that, they have to undergo this mutation and make many, many different variations of themselves to be able to recognize all the pathogens. And that's important for us because that means that B cells and T cells exist in clones. And a clone is just a group of cells that is genetically identical, that it has the exact same genetic sequence. And you might say, well, wait a minute, all of my cells have the same genetic sequence. So shouldn't all of my B cells and all of my T cells be clones of each other? And in fact, they're not. And the reason for that is the B cell receptor and the T cell receptor. So B cells are part of your humoral immunity. This is the part of your immune system that makes antibodies. And T cells are part of your cellular immunity. These are the cells that recognize cells that are normal and get rid of them. And the way they do that is that both B cells and T cells have unique receptors, either a B cell receptor or a T cell receptor, that are produced through a process of what we call hypermutation early on in the lifetime of these cells. And these unique receptors are able to recognize all sorts of different viruses and bacteria, et cetera, et cetera. And we take advantage of the fact that they have these unique B cells and T cell receptors because that's essentially a barcode. And we can use those unique B cell and T cell receptors to track the acute lymphoblastic leukemia over time. I'll point out that ALL cancer cells are not functional lymphocytes. They don't really contribute to the immune system. They don't help fight viruses and bacteria, but they do retain these unique receptors, and we can take advantage of that. And you probably have noticed that I'm talking about both B and T cell acute lymphoblastic leukemia. Both forms exist. B cell ALL is more common, and there have been more therapeutic developments in our ability to treat B cell ALL because we are able to target B cell antigens. T cell ALL is a little bit less common, and there have been fewer drug approvals and fewer new drugs in T cell ALL. So it's a very active area of research, and many of us kind of hope to see a similar evolution in T cell ALL. So what happens when we suspect that someone has ALL? We start with the initial diagnostics, and usually ALL manifests first in the blood. The way that we suspect that someone might have ALL is they come in and their blood counts are very low, or maybe they have some abnormal cells in the blood, and specifically the abnormal cells we're looking for are called blasts. And if we notice any blasts in the blood, we go looking in the bone marrow. The bone marrow is the factory of the blood. That's where blood is made. That is true in adulthood and in childhood. Interestingly, it's not really true in the uterus. So before a child is born, when an embryo is in the uterus, the blood is formed in the liver and the spleen. But in childhood and adulthood, the factory of the blood is the bone marrow. And so if you want to see what's going on in the factory and understand why the blood doesn't look right, you go and do a bone marrow biopsy. And I imagine that people on this call know very well what a bone marrow biopsy is. It's a procedure that, unfortunately, it can be quite uncomfortable, but when done well, shouldn't be painful, but it's never going to be comfortable. It's a procedure where the patient lies on their stomach, and we insert a needle into the skin, and we get through the skin, through the subcutaneous tissue, through the fat, and into the bone. The cortex of the bone is where the nerves are. The cortex is kind of the surface, the first layer of the bone. That's where the nerves are, and that's what can hurt during a bone marrow biopsy. And so the way to get around it is to put a lot of lidocaine at the top of the bone, and ideally put some lidocaine into the cortex of the bone so that one can numb the nerves. And I say that because some of my patients, they say, "Oh, this really hurt," when I did it somewhere else, and then when we did it at MSK, it didn't hurt so much. And I think one of the reasons that I've noticed is that we put a lot of lidocaine, and then we also give it some time. You need to give the lidocaine some time to work. I mentioned that in case people have had negative experiences with bone marrow biopsies. So when we do the bone marrow biopsy, we do a couple of things. First, we draw what is called an aspirate, which is you attach a syringe to the bone marrow biopsy needle, and you pull back, and you essentially pull the cells into a liquid suspension. And if you look at it with the naked eye, it looks just like blood, but it's not blood. It's a bone marrow aspirate, and it has tiny little spicules inside, and that's how you know that it's not blood and it's bone marrow aspirate. And then the other thing that we do is what we call a core biopsy. So we go on with a slightly thicker needle, and we take a core out of the bone marrow, very similar to how you would take a core out of an apple. And that allows us to then study the bone marrow under the microscope and understand more about the architecture. So when we do a biopsy, we send quite a few different tests, and we'll go through them one by one. The first test we send is called the surgical pathology. That's the most old-fashioned way of looking at cancer cells. This has been going on for many, many decades. Essentially, you take a specimen of the cells and you look at them under the microscope, and then you use your eyes and your visual recognition to decide if the cells look normal or abnormal. And what we're looking for here is blasts. So the hallmark of acute lymphoblastic leukemia is lymphoblasts or blasts. And here you can see with the arrows pointed what blasts look like. These are very immature cells. They have a lot of nucleus and not a lot of cytoplasm. Cytoplasm is the part of the cells that is not the nucleus. And if you look, for example, here to the right of the two cells with the arrows, this is a normal cell. This is a neutrophil. And you can see that, there's certainly a part of it that is nucleus, but there's also a lot of cytoplasm, whereas the blasts barely have any cytoplasm. And this is how we diagnose, this is how we've been diagnosing leukemia, for decades. From this kind of test, you cannot really tell if it's ALL or, for example, AML. All you can say is, well, it looks like we're dealing with a leukemia here, but you can't really say exactly what type of leukemia just by looking at it. Something that matters here is the blast percentage. So the pathologist will say, I see 25% blast or 85% blast or something like that. I want to point out that the blast percentage is important, but just having that number doesn't necessarily tell you that much. And just because someone might have more blast in the beginning rather than less blast in the beginning, it doesn't necessarily mean that much about how they're going to do with treatment. So it's an important number, but I don't think that people should kind of anchor it as something that will predict how they will do in the future. The next test we send, and that's very, very helpful, is called flow cytometry. So we take the cells and we stain them with antibodies. Essentially, we make any surface markers that they have fluorescent. We make them light up. And so, for example, a very important surface marker is CD19. CD19 is a protein that sits on top of B cells. And we want to know, okay, like off all the cells that we pulled from the bone marrow, how many of them have CD19? So we take an antibody that binds to CD19, and that antibody also has a little fluorophore. You can think of it as a little colored light. It's a red light or a green light or a blue light. And so now every cell has a little light tag attached to it, and then we run it through the flow cytometer, which is a machine that looks at the cells one by one. And the machine is able to read, okay, what kind of light does this cell have? Like, oh, this is a red light cell. Oh, this is a green light cell. And so then we take all this data and we integrate it and we're able to say like, oh, interesting. So, the lymphoblasts that we're looking at, they express CD19 and CD20. And if we see that, we say, oh, these must be B lymphoblasts because B cells express CD19 and CD20. And then conversely, there are other markers that we can look for T cells, and there are other markers that we can look for things like acute myeloid leukemia. And so this test really helps us make the final diagnosis. It helps us say, okay, are we dealing with an AML or an ALL? And if we're dealing with an ALL, are we dealing with TALL or BALL? This is a very, very helpful test that most centers do themselves. Some centers send to a central laboratory. The other nice thing about flow cytometry is that it tends to be relatively quick. So in our center, usually we get results within 48 hours. And other centers, it might take a couple more days, but it's relatively quick, and that's very helpful because it allows us to make some conclusions quickly. The next test we send is called cytogenetics. So every cell has DNA in the nucleus. That's our genetic code. And the DNA is packaged in chromosomes, and everyone is supposed to have 46 chromosomes. And usually you have 44 what we call somatic chromosomes, and then an X, and either a second X or a Y. And those two last chromosomes are called the sex chromosomes. And if you have XX, then you are female, and if you have XY, then you are male. Of course, that's not 100% true. There are situations where the chromosomes and the appearance of a person don't really match, but this is not the topic of this talk. But we look at the chromosomes under what was called a karyotype, and here on the right you see exactly that. You see a karyotype. We look at all the chromosomes and try to figure out, do all the chromosomes look normal, or have there been any breakages in the chromosomes? One thing that can happen when when cells become cancerous is the chromosomes can break. and then they stick to another chromosome. So let's say 9 and 22 break down. And instead of 9 sticking back to 9 and 22 sticking back to 22, they actually stick the wrong way. So 9 sticks to 22 and 22 sticks to 9. And we call that a translocation. And here you can see on the right, so if you try to look at 9, the 9 on the left is normal, and the 9 on the right is not normal. It's bigger than it should be. And then you also look at 22, and 22 also looks funny. One 22 is small and the other 22 is big. And what happened was, they broke and then stuck together the wrong way. This translocation, the translocation between 9 and 22, happens to be quite important. It's called the Philadelphia chromosome because that's where it was discovered. And when you find the Philadelphia chromosome in ALL, that is called Philadelphia positive ALL. And it's important because we treat Philadelphia positive in a very particular way. There's another rearrangement that you might hear about called KMT2A rearrangement or translocation. That one tends to be common in infants with ALL. And there's other ones that can be important. But the karyotype and the cytogenetics are very important in helping us figure out what is the right treatment for this ALL. Here I show you just a few other examples of cytogenetics. So on the left, you see hyperdiploidy. This means too many chromosomes. And you can see this person or the cell has many more chromosomes than normal. And then on the right, you see hypodiploidy, too few chromosomes. You see this karyotype is missing quite a few chromosomes. These things can both happen in ALL. And in the right clinical context, they can help us understand how the patient is going to respond to treatment. The other thing we do is called molecular testing. So, I was just talking about looking at the chromosomes, which are kind of like the DNA in large structures, but you can also look at DNA by sequencing the DNA and actually reading off the genetic code to identify if there's any mutations or sequencing errors. And some of those mutations are helpful in helping us figure out how the person will respond to treatment. Some specific mutations that we pay attention to, one is called TP53, and that's one mutation where generally, if it is present, the person might have a slightly lower chance of responding to chemotherapy. And then there's these three mutations that we also pay quite a lot of attention to, IKZF1, CRLF2, and JAK. The reason we care about them is because they may point towards something called Philadelphia-like ALL. So I told you about Philadelphia positive ALL. That's when you have that 922 translocation. But there's some patients that don't have the Philadelphia chromosome, but their ALL behaves a little bit like the ones that have the Philadelphia chromosome. And we call those Philadelphia-like. And again, that has some implications about what treatment we choose and how we choose to proceed. The other thing that we do at the initial workup is something called look at the VDJ locus. And that now goes back to what we were discussing, that all ALL, whether it's B or T, has a unique barcode because remember those ALL cells, they underwent that mutation process in order to create the unique B cell or T cell receptor. And so they have this unique barcode. And here I'm talking about B cells, but there's a similar process that happens in T cells. And for example, in B cells, the unique barcode is in a region called the VDJ region. So what we can do is we can actually read that barcode and then store it away and say, okay, great. Now we know what the barcode of these ALL cells is. And so in the future, when we're looking for ALL cells, we can use this barcode to look for them. This is the principle of something called next generation sequencing, or NGS MRD testing. And probably the best known test of this kind is clonoSEQ, which is a commercially available test, which does exactly that. It looks at the VDJ region and it allows us to track it in the future. And then lastly, these are the tests that we do from the bone marrow. As you probably know and have experienced, we also look for ALL in the central nervous system. That is in the spinal canal. So we put a spinal needle into the spinal canal underneath the spinal cord because, of course, we wouldn't want to touch the spinal cord. It's very sensitive. And we get a little bit of fluid and we send it to the lab to see if the ALL is hiding in the central nervous system because it likes to do that. The other place that ALL can go is in the extramedullary compartment. Extramedullary just means outside of the bone marrow. And so it can hide in lymph nodes. Sometimes it can go to the spleen or around the kidneys or things like that. And we can detect that with scans, like CT scans or PET scans. It's not really necessary to do scans in all ALL patients. Usually we start with a very good physical exam, and if there's any reason to suspect that the ALL is in the extramedullary compartment, then we do some scans. Lumbar puncture, on the other hand, pretty much everyone needs to have one because ALL does like to hide there. Okay, I'm going to pause and give you a very, very rough overview of what ALL therapy looks like. And this is not going to capture every single case, and it's not going to be comprehensive, but just it will help us anchor a little bit as we talk later. So for Philadelphia negative BALL, we usually give intensive chemotherapy, and we call that induction. And the goal of that is to get a patient into remission. Then we proceed with what we call consolidation, which is usually more chemotherapy. As you might know, there's a medication called blinatumomab that's an immune therapy, and we now have pretty strong evidence that it should be incorporated into consolidation for most patients. And then someone would go on to maintenance, which is milder chemo for 2+ years. This is a regimen that a younger person would get, someone maybe in their 30s or 40s. A person in their 60s or 70s might get a different regimen, but again, we're kind of very high level here. For Philadelphia, or sorry, for TALL, it's a very similar pathway, except blinatumomab doesn't work for TALL, so you wouldn't use it there. And then for Philadelphia positive BALL, the nice thing is that many times we can avoid giving chemotherapy. So sometimes we're able to start with just steroids and a tyrosine kinase inhibitor. That's a targeted therapy. Sometimes we might add chemo, but in many situations we're able to get away without any chemo, which of course our patients really appreciate. And then for consolidation, we give something like the TKI and blinatumomab, and maintenance might be just the TKI. The reason I show you this pathway is to also show you that there are many bone marrow biopsies along the course of this pathway. And, I've put some arrows here. It doesn't mean that this is exactly the number of bone marrow biopsies that a patient would get, but it gives you a little bit of a sense of when you might do the bone marrow biopsy. So you might do one right after induction, and then in the middle and the end of consolidation, and you do a few during maintenance. And the reason we do all these bone marrow biopsies is to try to figure out if the leukemia is still there or if we're progressing towards a cure, which is what we want. So when we do the repeat bone marrow biopsy, we try to figure out if the leukemia is still there. So these are kind of the categories that we look at. If there are more than 5% leukemic blasts, then we say that the patient has active disease, meaning they still have ALL. If they have less than 5% leukemic blast, but we can still find the leukemia, then we say that the patient is in complete remission, because anything that is less than 5% leukemic blast, we call complete remission. But if we can still find the leukemia, we say that the patient has positive measurable residual disease, or MRD. And if we cannot find the leukemia at all, then we say that the patient has negative measurable residual disease, or MRD. One caveat is that to be in complete remission, you also have to be free of leukemia in the central nervous system and also the extramedullary compartment. And so sometimes we might repeat some scans to look for that. How do we look for MRD, or measurable residual disease? We have a few different ways, and they're very similar to what we have already discussed. So we can use flow cytometry, we can use cytogenetics, we can use molecular testing. For example, we can look for the fusion that is created by the translocation between chromosomes 9 and 22, and we can use next generation sequencing. One thing that is important, and I want to point your attention to, is that these methods have different sensitivity, different ability to detect abnormal cells. So most of those methods are able to pick up 1 in 10,000 abnormal cells. So you basically, if you only have one abnormal cell among 10,000 normals, then you'll be able to catch it. But if you have fewer than that, then you might not be able to catch it with these methods. The most advanced method, the next generation sequencing, for example, clonoSEQ, is able to catch 1 in a million. So that is obviously very different, and it will be sometimes positive when the older, more traditional method would have been negative. And we're still trying to learn kind of what does it mean? If you only have 1 in a million abnormal cell, is that really meaningful? Does that really mean that the leukemia is going to come back? Or is that just kind of like a one cell that you picked up and the next time you're not going to pick it up? And we're still learning about these things. And so I do want to point out that this could totally happen, that someone could have flow cytometry and that's negative because it only looks for 1 in 10,000. But then the clonoSEQ might be positive because it's looking at 1 in a million. Um, the last thing I'll say is that this translocation of 9 and 22 and the gene that it creates, BCR-ABL, that one is a tricky one to interpret. So, someone might have Philadelphia positive BALL and they get all of their treatment and their, presumed cure of the disease, and suddenly we see a positive result for BCR-ABL when we test. That one is really tricky because BCR-ABL can sometimes also hide in the myeloid cells, which have nothing to do with the ALL. And in that case, they might not really be a problem. It might be okay to have a few myeloid cells that are positive for BCR-ABL, and it might not mean that the ALL will come back. And so these are kind of nuanced conversations where we have to look at all of the different tests together and kind of make a decision as to how worried are we that this ALL will come back. Okay, so before I go to transplant, I guess I'll just make one last comment on MRD. So we test MRD at many different time points. And in general, in the beginning of someone's treatment journey, it's okay to have positive MRD. So let's say, someone got just one cycle of induction, maybe a month of chemotherapy, and they still have some positive MRD. That's okay. We are willing to accept that and continue giving the treatment. The further and further along someone is in their treatment pathway, if the MRD is still positive, then one might want to consider changing the treatment or adding a new treatment. So, for example, if someone has finished their consolidation treatment and their MRD is still positive, if they haven't received blinatumomab, that might be a good time to add blinatumomab. If they have received blinatumomab, that might be a good time to think about other methods, like, for example, would this patient be a good person for a CAR T cell or a bone marrow transplant or something like that? So in general, MRD is okay in the beginning of someone's treatment journey, but the further someone gets along in their treatment journey, we really want to see that MRD go away and ideally go down to 0, because that's kind of the best chance that our patient is going to have to be cured of their disease. And so if that's not happening, then that might be an important moment to have a conversation and say, hey, is there anything else we want to do in terms of treatment to make that MRD go away? Um, and then I'll touch very briefly on transplant. So a bone marrow transplant is an allogeneic stem cell transplant, meaning that we essentially wipe out the patient's bone marrow and their entire blood system, and we introduce a donor blood system from either a related donor, like a sibling or a child, or an unrelated donor. And we've gotten very good in 2025 in finding donors for most of our patients if we need to. And the reason we do that is because we want the new immune system, the new bone marrow, to essentially find any ALL cells that might have been hiding and kill them. And so the goal is to cure the patient with a new bone marrow. And again, not every ALL patient needs a bone marrow transplant to be cured, but some do. And there's some special testing that we do in order to do a transplant. So one of the things that we do is we do HLA typing, and you might have heard about this, but essentially all of our cells, and in this case, all of our white cells, have different markers on top of them. And in order to do a transplant, those markers need to be compatible, or at least compatible enough. And so what we do when we do typing, we read off those markers, we read off all the HLA antigen, and there's usually 4 to 12, or sorry, 8 to 12 different locations that we read those HLA antigens. And then we use that to match the person. And so, for example, if you take two identical twins, they would be a 12 out of 12 match. Everything would match because they are genetically identical. If you take a parent and a child, there will be a half match because half of the DNA came from one parent and half of the DNA came from the other parent. And so by definition, a child and a parent are a half match. And again, in 2025, we are able to do half match transplants. And so, sometimes we use a parent and a child or something like that. And then the last test that you might hear about in a transplant setting is the chimerism test. So a chimera is a Greek mythological term, and it's an animal that was composed of two different animals. And so in medicine, when we use the word chimera, we essentially mean not an animal, but a person who is composed of cells from two different origins. And so, for example, someone who has had a bone marrow transplant has their own cells in the rest of their body, but in their bone marrow, they have someone else's cells. And when we do a chimerism test, what we want to ask is, within the bone marrow, how many of the cells are yours and how many of the cells are coming from the donor? And that's important because we want the donor to completely take over time. And we don't want to see a lot of residual cells from the recipient over time. And one kind of old school way of doing it is, let's say if the donor and the recipient are of different sex, you can look at the XY and XX chromosomes in order to do that. But now we have more modern methods of assessing chimerism that are based on sequencing. And so ideally over time, we want to see the chimerism increase to 100% donor. Again, it's okay if that's not true in the beginning, but over time, we generally want to see that. Okay, so that's all I have. So I will stop here. I'll just say again, I will not be able to answer kind of very specific clinical questions about any individual cases, but I'm very happy to take any general questions or discuss anything that wasn't clear.
Thank you. That was really clear for me. That was really interesting. And yeah, I'm opening the space for everyone. If you have any questions, feel free to drop them in the chat, or if you want to, you can also raise your hand and ask them yourself. In the meantime, we get a few questions. Sometimes results can look worrying. Sometimes lab results can look worrying, and but the patient feels fine, or the opposite. So how should patient balance what the labs show with how they feel day to day?
Yeah, that's a really good question. And we all live at a time where patients have access to their results almost immediately, and sometimes before the medical team has reviewed it, which I think is great. I think at the end of the day, it's your own blood test, and I think people are entitled to know what the result is. But it can be very stressful. I guess what I would say is, again, every lab test needs to be put in context. So, for example, if you have an MRD test that is positive and you're early in your treatment journey, that's not really worrisome. That's okay. But if you open your portal and you see MRD positive, you might be quite upset to see that. So I would say the most important thing is to put the lab test in context, and probably the best person to do that for you is your medical team. And so, your physician and your nurse practitioner will be able to put it in context and say, you know what, actually at this time point, we're not really worried. We're very comfortable with you having some MRD, or, because it's later in your journey, we're hoping that you would be MRD negative by now. And so, let's discuss what we're going to do in order to achieve that. I also saw Susan ask, can all of the MRD tests be done on peripheral blood? That's a great question. So flow cytometry and clonoSEQ can definitely be run on peripheral blood, as can BCR-ABL PCR. So the answer is yes, all of them can be done from peripheral blood. The difficult question is the sensitivity any lower from peripheral blood than it is from the bone marrow? And the answer is probably yes, it's probably a little bit lower. So let's say like if you only have 5 cells in a million, 5 abnormal cells in a million in the bone marrow, and you do the test from peripheral blood, you might not be able to catch them, or you might only catch one of them. Um, the tough question is, well, how important is that? Do we really need to catch those 5 cells in a million or no? And the honest answer is we don't really know yet. So if you survey different ALL doctors, you will get different answers with respect to how many bone marrows you need and how many bone marrows can you replace with peripheral blood testing. I would say my personal opinion is that we're not yet at a point of replacing all of the bone marrows with peripheral blood and saying, you will never need a bone marrow again. But we probably are at a point of replacing some of them. And so, like, for example, during the maintenance time and during the follow-up time, you might be able to do, the MRD testing from peripheral blood every 6 months, and then the bone marrows every 6 months. So that way, every 3 months, you have one or the other. So I would say that that's still an area of active investigation. But yes, we can get a lot of information from the peripheral blood.
Thank you. Also, I received a question ahead of the time, and this patient was wondering, like, How does doctors use my labs and genetic results, whether to decide if I'm a patient with standard risk or high risk, and can that change over time?
Oh, yeah, that's a very good question. And I will say those definitions of standard risk and high risk ALL are very robust in pediatrics, and we have very strict criteria for what counts as high risk or standard risk in pediatrics. And in fact, they get rather different treatments. Like all of the pediatric protocols kind of give different treatments to those patients. In the adult ALL world, I would say those definitions are not as clear cut. And if you ask different physicians, they might give you different answers as to what is high risk ALL. The other thing is that our treatments are evolving so rapidly, like the availability of immune therapy is evolving really rapidly. And what we used to think of as high risk might not be so high risk anymore now that we have some of the immune therapies. And so I guess I would say it's not as straightforward as it used to be. It's not as straightforward as it is in pediatrics. The way I usually think about it is not so much about classifying a patient into high risk or low risk, but more kind of thinking of like, what are the high risk features? Like, what about their leukemia could get them into trouble later on? For example, is there a particular mutation that, could get them into trouble later on? Is there a particular translocation? And how are we going to tailor the treatment to basically minimize the chance that this leukemia would get them into trouble later on? I guess the last comment I'll make is one of the things that certainly isn't favorable and is higher risk is when a patient is not able to clear their MRD. Again, early in the treatment journey, it's okay to have MRD, but like after consolidation or into maintenance, you really should be getting rid of the MRD. And if that's not happening, that is a high risk feature. And so the patient and their doctor needs to sit down and discuss like, okay, what are we going to do to get rid of that?
Awesome. I also have one that I thought it was really interesting. Says my mom has multiple myeloma, and with her, I've learned which specific labs I need to be watching, her M spikes, her light chains. And now that I have ALL, I wouldn't know which labs are the most important for me to follow, like which numbers I should really pay attention, which ones I should follow trends. That is there anything you can tell me?
Yeah, no, that's a really good question. And we don't have a what we call a biomarker as good in ALL as we do in multiple myeloma. So in multiple myeloma, we're able to follow the M spike or the free light chains, and those give us kind of real-time information. In ALL, we don't really have that. I would say the numbers that I always pay attention to is the blast percentage. So the blasts can be in the bone marrow, but they can also be in the blood. And ideally, I want to see the blast percentage go down as someone gets into their treatment. So I pay attention to that. And then I pay attention to all of the MRD numbers, either from the flow cytometry or from the clonoSEQ or from the PCR, if it's a BCR-ABL positive case. And I look at those numbers, and again, I want to see them all go down over time.
That's that helps a lot. And sometimes different tests and point in the same direction. And I think you mentioned this before, like one result looks encouraging, one other raise concerns. How do my doctors weigh and interpret this conflict of results?
Yeah, again, a really good question. I think we always just have to put the test into context and remember that, some tests are designed to be more sensitive. And so they might pick up like tiny, tiny amounts of leukemia that, a few years ago we would have never been able to pick up. And so, we're still learning exactly what to do about that. But I would say definitely if two tests look conflicting with each other, talk to your doctor and kind of, ask them to give you an explanation of what's going on. I mean, I think in 2025, true lab errors and like lab mix-ups are very, very rare, but they're not impossible. Like it is theoretically possible that, the lab made an error and, the specimen wasn't, handled properly. And so sometimes if there are two tests that really don't make sense, we might say, okay, let's repeat the testing, to see what's going on.
That makes sense too. Well, I think that I don't know if anyone in the audience have more questions, but those are the ones I receive ahead of time for patients that will watch the recording. But I think that was amazing. I really feel more aware of what truly this labs means and when to worry and what not to worry. So I do have a couple of extra slides, but first, again, like, thank you for your time.